So today, let's make the assessment station in the mental health nursing Osce very simple for you. Now, I've had a lot of people who always say that the assessor starts the timer, my 20 minutes time. I have a depression with suicidal ideation patient or I have a manic patient and I'm completely speechless right from the beginning. I don't even know what to say. Now, in this video, I want to make things very simple for you as far as the assessment station in the mental health Osce is concerned. My name is Enos and this is Work and Wonder. If you've not subscribed to my channel, please turn on the notification bell and subscribe to the channel. I talk a lot about the mental health nursing Osce and today is of no exemption. And today, as I said in the introduction, I will be talking about the assessment station. Now, I want to make the assessment station very simple for you. I've had a lot of comments and then they're like, immediately the assessor starts the timer, their mind goes blank. They become very confused. They don't even know what to say. It takes them time before they will be able to even start the assessment station. Now, we know already that in the assessment station, either you are going to get a patient who has depression or you're going to get a patient who has mania. These are the only two phases. And you have 20 minutes to complete this particular assessment. Now, the very first thing that could be very helpful is the documents that they give you. Now, if we look at the very first document, that is a scenario. The scenario exactly tells you what you are doing and what setting you are in. We know that it could be a community setting, it could be an admission-based or a hospital-based setting. The community simply means that it's either the patient is coming to the community clinic for an assessment or you as a mental health nurse, you are required to go to the patient house to go and conduct the assessment for that particular patient. That is for the scenario. Paper number one. Now let's move on to the second one. The second one will be overview of the patient history. Overview of the patient history gives you a lot of information, but students usually don't take note of this and then they are just in a rush to start. Don't be in a rush to start your assessment. You have a whooping 20 minutes to start. So if it is going to take you 5 minutes to read those documents and understand it and know exactly what you are doing, you are good to go. Use that 5 minutes. Don't start abruptly like that and then your mind just go blank. You don't even know what to say to the patient. So the overview of the patient history gives you a lot of information. When we look at the very first part of it, it talks about the bio data, which is the name, the date of birth, the hospital number, or the clinic number, or whatever biodata they give, the age of the patient and all of that. Then when you come down, it talks about the current presenting complaints, which is one key thing. When we talk about the presenting complaints, it talks about what currently in terms of mental state the patient is exhibiting. So the patient is suicidal, the patient tried to self-harm. All this information you'll find it that this patient is self-isolating, the patient is not talking to anybody. In terms of personal hygiene, the patient is not taking care of his personal hygiene. In terms of nutrition, the patient has not had any proper nutritional intake for the last 5 days. So you see that the presenting complaints, there's going to be tons of information there which could be very helpful. And at the same time, sometimes if they've self-harmed before, if they self-harm before, if they have self-harm before, you are going to see that information also there. And then when you come to the past medical history, of course, as I've said in some of my videos, most mental health patients, they've been diagnosed and they're already on some form of medication. So there might be a history of the patient being admitted before or diagnosed of depression 2006, diagnosed of this. So there is a bit of information with regards to their medical history where you find some bit of mental health diagnosis in there. Aside that, when you go down, you see the social history, which is also very important. Here they tell you the patient relations that he or she has. The patient has a brother, the patient has a sister, the patient has an elderly mother, the patient has a father, the patient has an auntie, he stays with this, the number of dependents, the patient has the number of pets, whether the patient drinks or not, whether the patient smokes or not. So tons of information in the social history. Then I think when you go down, you're going to find medication history. So as I said, if the patient has been diagnosed of some form of a mental health condition, it is likely that they are going to be on some form of psychotropic medication. And of course, the last thing is always the allergies. So if you take your time and then you read this, now you have a bit of a social history of this patient. And once you know their social history, you can build on this social history to ask relevant questions. I will get there in a bit. But now I want us to look at the third document that will be given you, which is the candidate note. Candidate note, as the name suggests, is for you. Whatever you write on that candidate note is for you. They are not going to mark it. But interestingly, they have kind of summarized the various topics under which they want you to ask your questions. So if you look at the very first component on the candidate note, you are going to see capacity and consent. Capacity and consent, obviously, you will be assessing, but of course, that will be the last thing that you would have to assess, because you can't start an assessment and all of a sudden you know whether the patient has capacity or not until you ask questions, and then based on the answers that the patient will give you, you'll be able to determine that. But the next thing is relationship. Now, if we look at relationship has got to do with the kind of relationship that the patient has with his immediate family and then friends, and whether that relationship is beneficial for the patient in terms of supporting his mental health or not. So now you can see that in the overview of the patient history, you have the social history, which will tell you the mother, whether he has a mother, whether he has a brother, whether he has a father. Now, when we come to the relationship, what you can simply do is that you can just look at the social history. The patient has a mother, you can say that, how is your relationship with your mother? Has your mother been supportive in this situation that you are in currently? Or I can see that you have a brother. In that first scenario where I said that the brother brought him to the A&E, you can simply ask, your brother found you unconscious and brought you here to the A&E. How is your relationship with your brother? Is your brother very supportive of you? You are just taking it bit by bit. You are just building on that. Now, when we go to major life events, usually when you ask the patient what has been happening currently or of late, what is happening to him, then whatever they are going to say is all going to be revolving around the major life event. So they will start telling you about how they had a good relationship with probably their fathers or their mothers, and all of a sudden there was a breakdown, or they lost a loved one, and that is where all these mental health issues started, and that is what instigated all these signs and symptoms that he or she is currently experiencing, and all those are going to be the major life event. Then we also have living situations. In terms of his living, how is his living situation like? Is he working? Is he on any benefits? How is he able to fend for himself or herself? These are living situations that you have to explore. Then when you go down on the candidate note, you have adherence to medication. So here, if the patient is already diagnosed with some form of a mental health issue, usually they are going to be on some psychotropic medication. So you have to find out the adherence to these medications, and if they have any physical health problems like diabetes, like hypertension, they might be on some hypertensive and some diabetic medications. You would also have to ask questions around that. And of course, then you're going to have the current risks, which when you run through from the first question on the candidate note to the last, by that time you should be getting some, based on the patient answers, there should be some risks that are prevalent there. So this is the third document that will help you to be able to ask your questions. Now, if it is depression and suicidal ideation, you know that you will also be given a patient health questionnaire. This is basically a tool that was developed by BAPEN, and then this is used in the assessment of the severity of depression. So it is only in the depressive phase that you would be given this particular document as well. And this document can really help you to be able to ask the relevant questions, because it has these nice structured questions on it, and these are like problems that the patient has undergone over the past 2 weeks. So you just mention it to the patient, and there are grading on it from a grade of 3. So it's graded on a scale of 0 to 3, where 0 means they are not experiencing that problem at all, and 3 means they are experiencing this almost every single day. And then at the end of it, you are going to calculate the score, and then at the back of the sheet there are some provisional diagnosis that has been provided for whatever score that you are going to get at the end of your calculation. So these are the documents, or these documents that they provide you with are relevant documents that can help you to be able to get the relevant questions to ask your patient. Now let's start from the top. Now I always say that before you even be able to engage with somebody that you do not know, the very first thing has always got to do with rapport. If you establish a very good rapport right from the beginning, then the assessment is going to run smoothly. But right from the beginning of the assessment, if you are anxious, I know that is an exam situation and most of you will be anxious. But right from the beginning, if you are too anxious and you are not able to establish that good rapport with the patient, then the assessment is just going to be on and off. So right from the beginning, for example, in this situation where you work within the mental health acute unit, you are the patient was brought to the A&E unconscious by the brother, and they've referred this patient to your ward, or they've referred this patient to you to come and do an assessment. And if they need be, probably they transfer the patient from the A&E to the acute mental health ward where you work. If this is your scenario, and then you do all your initial checks, your hand rub, your scene safety, and now you start to talk, you sit down and then you start to talk to the patient. You can start off by introducing yourself again. So my name is Enos, and I work within the acute mental health ward. I've been working there for the past 10 years now, and these are more or less like my usual routine. I get called a lot here to the A&E to usually come and do an assessment. So I completely understand your situation because I've been doing this for more than long enough. And always when I come here, I try as much as possible to help whoever I am here to do the assessment for, and you have no reception. So if you see me here, don't be so much bothered. I just need you to be as open as possible so that we can have this assessment. We'll be able to explore your risks, and then we'll be able to together find interventions which will be helpful for you. So Mr. ABCD, are you willing to work with me now, or are you willing to engage with me in this assessment so that we'll be able to find the right interventions for you? Patient would, if you put it this way, the patient is definitely going to say yes, 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 if that is the case. So now you've introduced yourself, you've made the patient understand that this is something that you do, and you've made the patient also understand the purpose of you being there. You are there to help the patient. So right from there, if the scenario as they brought him unconscious, then you can ask the patient. So prior to your brother bringing you here, I know you just woke up, or you opened your eyes when you were already in the hospital because you were brought in unconscious, and I know very well that probably you didn't even know how you got here. But then, can you remember anything from the last 5 hours or the last 6 hours, or prior to they bringing you here? Do you remember anything that you did, or do you remember doing anything? And here the patient is likely going to open up and tell you exactly what led to him or her being unconscious. Mostly scenarios like this might say that the patient tried to self-harm by either hanging or taking lots of his or her medications, and the patient will tell you this. But when the patient tells you this, oh, I tried to self-harm, I find that life is not worth living, and blah, 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 they are going to tell you a whole lot. And that is why I tried to self-harm, and then I just opened my eyes and I found myself in the hospital. So in this situation, the patient has told you what he did, and then he went, unconscious. So at this point, you can now delve deeper. So what do you think triggered this, or what made you to want to self-harm? And then the patient will open up and, of course, tell you what made him or her self-harm, and then went unconscious, and they brought him or her to the hospital. Then once you are done exploring that, you can also ask, you can go, you are using the candidate note, so now you can go back to the relationship. So I understand as your brother that found you unconscious and rushed you to the A&E. Do you have a very good relationship with your brother? Patient is going to tell you. How supportive has your brother been, or is your brother supportive of you in this your tough times that you are going through, or in terms of the time where, or this period where you've had so much issues with your mental health? How supportive has your brother been? If in the social history you realize that the person has a mother or a brother or a sister, you can also ask, you can also ask the patient his or her relationship with his brothers and then his sisters or his other siblings that he has, and how that relationship is. Is that particular relationship beneficial for the patient, and how is it helping with his or her mental health? Aside that, when you're done with that, the living situations, as I said, for example, if they say that the patient is a teacher, is a secondary school teacher, you can just go straight ahead and ask, I can see that you are a secondary school teacher. How is that going? And then the patient will tell you. Or you can ask the patient, what do you do for a living? And then the patient will tell you, are you on any benefit? How in terms of your finances, how is it? So you are basically exploring his living situations to see, because mental health can deteriorate if the person is going through stress in terms of his finances or in terms of his living situations. Some things are not going well. All these are things that can deteriorate the patient's mental health, and it is worth asking. Now, when you get to the non-adherence, of course, you can ask the patient whether he knows the medications that he's on. If the patient responds, you can ask him whether he or she has been taking those medications as prescribed. If the patient is not taking it, try as much as possible to also explore why the patient has not been taking it. Is it a side effect of the medication? Is it that the patient doesn't even have a clue as to what the medication does for him or her? Try to explore around that, and then you'll be able to know exactly the reason for the patient not taking his medication. And then, of course, the last thing will be the current risk. So at this point, at least if the patient is not taking his medication, that is a risk. If the patient is constantly having thought of self-harm, that is also another risk. If the patient, in terms of his nutrition, is not also eating or has not had any proper nutritional intake for the last few weeks, this is a risk for malnutrition, which is also another concern. You can also add that as the current risk. And then among other risks that you can find with that particular patient, you can document them at the current risks. And when you are done with that, you've gotten more than enough current risks. You can feed these risks back to the patient. At this point, this A, B, C, D is your risk, and then you throw it back at the patient and try to see whether the patient actually has insight into this, whether the patient actually thinks there's risks, these are risks, and these risks are prevalent, and these are making his mental health worse or not. Based on the patient answer, you'll be able to know whether the patient actually has capacity or not. So yeah, basically that is it. The assessment is really, really very, very, very simple. It's just a matter of you putting yourself in that situation where you make it look more like it's a conversation that you're having with the patient, more a conversation that you're having there with the patient. If you make it look like you are doing like a formal interview, then it is just going to be a question and answer section, which wouldn't be very, very helpful. But with assessment, it's more of like exploring to know what is actually making the patient mental health worse, and what the two of you, or what you can explore to make the patient better in terms of his mental health. And then at the end, based on the risks that you are able to come up with, you'll be able to determine whether this patient needs to be transferred to your ward for continuity of care, or if the risks are not really that grievous, you can just the patient can be discharged back to the community, and then continuity of care can continue there. So basically, this is how simple the assessment station is and how you'll be able to ask the relevant questions that you're supposed to ask in order to be able to do your assessment. I would also encourage all of you to have a read at the recovery model of care. When you go online, just type in the recovery model of care for mental health, and then it is going to tell you a lot about how various mental health institutions make use of this model. It's a really, really, really good model which focuses on the functionality of patients, and then how you'll be able to improve that. It's a very good model. Have a read at that, and that should be able to also help you in terms of how to be able to do an assessment in either a manic situation or in a depressive with suicidal ideation situation. Basically, that is it. It's as simple as this, and this has been the video for today. My name is Enos, and this is Work and Wonder. Please, if you've not subscribed to the channel, please and please make sure you subscribe to the channel, and then share to other people who may also be interested in mental health nursing. Until I see you in my next video, it is a bye for now.